disease. And Leo's expanded his interest now. I think you're particularly taking interest in atrial fibrillation, Leo, and personalised medicine, dementia after stroke, and coordinating the Swiss stroke registry. And in fact, you're probably our inaugural speaker from another unit. Generally, we've had home speakers for this meeting, so we're really pleased and honoured that you've taken the time out to speak to us, Leo. And we're looking forward to your talk, which I think is about intracranial and extracranial atherosclerosis. Is that the title?
That's correct. That's the title. So thank you very much, David. And I'm going to share the screen. We did experience a few problems before. I hope you can see my screen. David, maybe you can confirm. Yeah, seems to be the case. Very good. So thank you very much, David, for the kind invitation and introduction. And it's really my pleasure to speak to you today about the management of atherosclerosis of extracranial and intracranial arteries. I experienced some technical glitches when I tried to go into presentation mode just before, so I'm going to keep it in the normal PowerPoint mode, but the slides are quite large, and whenever there's a problem, I can still try and zoom in, but it should be okay. We have plenty of time. I think the lecture will take maybe 50 to 60 minutes max, and then we have, I think, about half an hour, plenty of time for discussion. So now I'm going to have to use the page down button. Here we go. The lecture outline is that I would first speak about the epidemiology and pathophysiology of carotid disease, because it's a model for atherosclerotic stroke and important in understanding the effects of medication, but also patient selection, plaque imaging, etc. And I'm first talking about medical therapy because a lot of studies have arrived in the last years that are relevant for the conservative management of carotid artery disease, and all invasive treatments that we're offering should always be seen in the context of optimized medical therapy. And I'm focusing here on antithrombotic therapy, both in the acute, post-acute phase, but also in the stable phase, and a brief word about cholesterol targets. And then I will show the existing randomized clinical trial evidence on endarterectomy and stenting for carotid artery stenosis, separating the data from patients with symptomatic stenosis and patients with asymptomatic stenosis that largely form the basis of various various management guidelines that are out there at the moment. So I will then speak about some about patient selection with a focus on plaque imaging, specifically plaque MRI, and then a few words about stenting for symptomatic vertebral and intracranial artery stenosis. And then I will finalize the talk with some management recommendations, which are in part personal recommendations, but also as far as carotid disease is concerned and stenting and endarterectomy are concerned. I will present you the newest ESO guidelines on management of carotid artery disease that we published this May. So the word carotid comes from the Greek word karo, which means to plunge someone into deep sleep. And of course, when you compress somebody's carotid arteries, you will put him or her to sleep. And so for a long time, a reduction in cerebral blood flow was considered to be the principal mechanism by which carotid stenosis can lead to a stroke. And now today, and usually this slide is animated, so you have to bear with me in this with the still version here. But today we understand that it's usually embolism causing stroke or TIA in symptomatic carotid disease, and largely also generally in large artery atherosclerosis when it is causing these symptoms. So you have a cholesterol buildup in the wall, inflammation, forming a plaque, and that can lead to a stenosis or an occlusion of the artery. But more often, at some stage there will be a rupture in the plaque surface, and then you will see you will have locally formed thrombus or plaque material embolizing to the brain. And so we think that large artery disease causes, large artery atherosclerosis causes about 15% of all strokes. And it's globally a relevant problem. These are quite recent data from the Lancet Global Health from last year, a systematic review and modeling study of all the published screening and observational studies so far. And you can see that a substantial proportion of persons aged 30 to 80 years have carotid plaque. And in this study, this was defined as at least 1.5 millimeter protruding into the lumen. And actually, globally, 1.5% of people have carotid stenosis, which was defined here as at least 50% narrowing down of the lumen. And you can also see a couple of things. It's more frequent in men than in women, and it steeply increases with age. So I think with global changes in demographics, we will see more and more carotid disease globally, even though I think the risk with good medical therapy now is going down. We will see more of these cases because people get older and are more likely to acquire manifest carotid disease. So before we go into medication, we need to understand a few things about the atherosclerotic disease process and where the most important agents work. So initially, we have cholesterol deposition and cholesterol oxidation in the artery wall, and this triggers an inflammatory process, which is largely cellular with the macrophages and T cell infiltration. And these inflammatory cells release cytokines and enzymes that destabilize the connective tissue in the plaque. And then eventually the plaque can rupture or ulcerate, and then locally thrombus can form and embolize to the eye or to the brain, as I have just shown you a few slides earlier. And statins mainly act by reducing the cholesterol that's deposited in the wall. They might have some pleiotropic effects in that they are thought to act in an anti-inflammatory way to some degree, but this is often disputed. And on the other end, at the other end of the spectrum, you have antithrombotic medications that counteract the local formation of thrombus in case of an ulcerated or ruptured plaque. And again, these antiplatelet agents may have some anti-inflammatory properties working along the way. And it's pretty sure that blood pressure lowering is important throughout all the stages of the atherosclerotic disease process. So these are, again, the main mechanisms and the main target areas for medication of carotid stenosis and of atherosclerosis in general. So when we now move on to medical therapy, I'd like to focus on antithrombotic therapy first. And you're aware that in the last few years, a number of studies have evaluated aggressive antiplatelet regimes, not specifically in patients with carotid disease or atherosclerosis, but as a means of early secondary prevention in patients with minor stroke or TIA in general. And one of these pivotal studies was the Chinese CHANCE study that randomized more than 5,000 patients to dual antiplatelet therapy with clopidogrel and aspirin. They used a 300 milligram clopidogrel loading dose, and dual therapy was continued for 21 days versus aspirin therapy alone. And what you can see is that after 90 days, the primary outcome event, which was any stroke, so combining ischemic or hemorrhagic stroke, was reduced by dual therapy by about 2.5% in absolute terms, or even 3.5%, I'm sorry, in absolute terms. So quite a substantial effect. But what you can also see is that a lot of this difference occurred very early on, in the first few days after initiation of therapy. Now, in that study, they did a sub-study on whether or not patients had atherosclerosis, and they didn't look at carotid disease because carotid disease is not as common in China as is intracranial stenosis. So they specifically looked at intracranial stenosis being defined as more than 50% in the artery that was thought to be responsible for the initial TIA or stroke event. And it's remarkable that almost half of the patients here had at least 50% intracranial stenosis. So much more common than in Western European or North American populations. And the other thing that was striking, and of course we have to take this with a grain of salt because it's a sub-study and it's a subgroup analysis, but what is striking that it appears that in the sub-study, only the patients with intracranial stenosis appear to have benefit from dual therapy with aspirin and clopidogrel. And there was another study, the POINT trial, done in North America and in Europe, which again confirmed the efficacy of dual antiplatelet therapy with clopidogrel and aspirin in patients with minor stroke or TIA. Now, a bit more recently, the THALIS study was published. This was a study evaluating the combination of ticagrelor plus aspirin versus aspirin alone, again in patients with minor stroke or TIA. And they had any stroke or death in the first month as their primary outcome, and they were also able to show that the combination of ticagrelor and aspirin reduces the risk of this endpoint significantly, although it was less of an effect in absolute terms as was seen in the CHANCE study. It was about a 1% difference rather than a 3% reduction, but the underlying baseline or background stroke risk, if you want, was also somewhat lower in this study. And again, you can see this pattern that the difference between the two arms arose in the first few days after initiation of therapy, and thereafter the curves are more or less parallel. So this seems to be an effect that takes place early on, and I think it highlights the importance of starting aggressive antiplatelet therapy in patients who are suitable for this therapy or not at increased risk of bleeding early in all patients with minor stroke or TIA, and probably especially in patients with underlying atherosclerosis as the cause. Because, again, in the THALIS study, they now did a sub-study not with intracranial stenosis, but with any relevant or potentially relevant ipsilateral stenosis, be it in the extracranial artery, in the vertebral artery, if it was a vertebrobasilar event. And they just looked at whether this was more than 30% stenosis or less than 30% stenosis. So quite a low cutoff. But again, they were able to see that in the sub-study, it was the patients with ipsilateral stenosis that had benefit from dual antiplatelet therapy with ticagrelor and aspirin versus placebo plus aspirin. And here they were actually able to show quite a substantial 3% risk reduction in the primary outcome of stroke or death. So again, the signal that the effect is early on, and the effect is especially present or especially pronounced in patients with symptomatic large artery atherosclerosis. Now, if we move on to more stable carotid disease, so let's say symptomatic carotid stenosis, but the symptoms occurred a few months back, or asymptomatic stenosis, which is usually defined as no symptoms at all or no symptoms in the last 6 months at least, then we can consider the data from the COMPASS study. The COMPASS study was an interesting trial comparing a combination of low-dose rivaroxaban, twice 2.5 milligrams daily, plus aspirin 100 milligrams daily, versus aspirin alone. And the initial study was in patients with either coronary artery disease or peripheral or carotid artery disease, but it was all stable disease. It was not acutely symptomatic patients. And the primary study was significantly showed a significant benefit of dual therapy with rivaroxaban plus aspirin. And this was also shown, and this is what this slide tells you, in the subgroup of patients with peripheral and carotid disease alone. So here you have the treatment effect in the overall COMPASS study, and you can see maybe there is even a trend that patients with carotid disease had particular benefit, but of course the confidence interval is quite large. So, but again, it confirms that in stable carotid disease, this type of therapy, which is a combination of low-dose anticoagulation and aspirin, and here you can see the curves, is in the long term maybe more effective than just aspirin. Now, just a very few words about cholesterol targets. Now, when you follow the guidelines in Europe, so the European Society of Cardiology guidelines and the European Atherosclerosis Society joint guidelines, then they use a target level approach, which means they categorize the vascular risk of a patient and then recommend a specific LDL cholesterol target. And it's important to understand that very high cardiovascular risk, the highest category, is defined as any documented cardiovascular disease. This can be clinical, so this would apply to any patient with a TIA or stroke, or unequivocal on imaging, and this includes significant plaque on carotid ultrasound, for example, or on CT angio, and it's not quantified what significant plaque means, which sometimes puts you in a dilemma when you have a patient with just a minor plaque. But anyway, in these patients, very strict LDL cholesterol targets are recommended. It used to be below 1.8 millimoles per liter in the 2016 guidelines, and in the update a couple of years ago, this was actually lowered further down to 1.4 millimoles, partly because of the results from the PCSK9 inhibitor trials that showed in high-risk patients, even if you go to very low LDL cholesterol levels, you have greater benefit. Now, it's possible that, or it's actually likely that, these advances in medical therapy, together with awareness about the need for early endarterectomy and stenting, have lowered the risk of having a stroke in symptomatic carotid stenosis, in particular, or in symptomatic large artery atherosclerosis in general. Because if you look at the left-hand side, you have these observational TI registry studies that were done about 2 decades ago, and they consistently showed, and this is the bottom Kaplan-Meier curve here, that if your initial TIA was caused by atherosclerosis, you had the greatest 3 months risk of a stroke, which is about 20% at the time. And when you compare these data with more recent registry data, this is the TIA registry study by Pierre Amarenko, and he showed that again, large artery atherosclerosis as the underlying cause still confirms the greatest risk of stroke after TIA, but this has gone down a lot. It's just about a third now. It's just about 6% risk of a stroke after 3 months, as compared with 20% risk 10 to 15 years earlier. So when we now go into invasive treatments such as carotid endarterectomy or stenting, we always have to bear in mind that especially the early carotid endarterectomy studies were done against just giving aspirin to the patient. They were not comparing endarterectomy on the background of aggressive cholesterol lowering, strict blood pressure control, initial dual therapy, etc. So we have to bear that in mind when we judge the effect of these treatments today. Now let's go on to endarterectomy. Endarterectomy is a surgical procedure to remove the atherosclerotic plaque, and it involves an incision in the neck, and you know this can be done in local anesthesia or general anesthesia, and Here you can see an endarterectomy specimen where you have a completely calcified plaque that was excised from a patient's carotid bifurcation. You can see this is the internal carotid artery. This was the external carotid artery. Maybe you can see some ulceration here. So it's easy to think that if you remove this from a patient, you should be able to lower the stroke risk. And in most cases, this is true. And this was shown early on in trials that were conducted almost 3 decades ago now, against the background of just aspirin therapy. We have to bear that in mind. So if you look at the evidence on endarterectomy versus medical therapy in symptomatic stenosis, then we can refer to this beautiful individual patient data pooled analysis by Peter Rothwell done in 2003. And he showed that if you combine the data from all the 3 trials that were done at the time, the North American, the European carotid surgery trial, and the Veterans Affairs study with more than 6,000 patients, you had a 16% stroke risk reduction with endarterectomy compared with medical therapy alone in patients with severe symptomatic stenosis, but only a 5% stroke risk reduction after 5 years in patients with moderate symptomatic carotid stenosis. How about endarterectomy for asymptomatic stenosis? So before symptoms occurred, and again, this was tested in 3 large randomized trials, and Alison Halliday and her team in Oxford, just after many years, were able to obtain the individual patient data of these trials and put them together in this nice, again, pooled analysis that was just submitted for publication. And it shows that in patients with at least 60% asymptomatic carotid stenosis, endarterectomy reduces the long-term stroke risk by about 4.5 to 5%. And this is achieved after about 5 years, even when we take into consideration the early risk of perioperative stroke or death, which was about 3% in the study. So later on, the operated patients had a lower stroke risk, and this was stable throughout about 10 years of follow-up. So again, as in symptomatic moderate stenosis, we have a modest effect in patients with asymptomatic stenosis from endarterectomy. And again, have to bear in mind this was largely done compared against aspirin alone. Only a minority of patients in this trial had statins early on, but that proportion increased towards the end of the follow-up period to almost 80% of patients. So another way to invasively treat carotid stenosis is carotid artery stenting, and hereby we don't need to cut open people's necks. The radiologist can insert a catheter, usually at the groin, advance the catheter, the guide wire across the stenosis, and place a stent, so a small metal tube across the stenosis and dilate this, and this will open up the artery from the inside. And stenting has been compared, or was compared, with endarterectomy in a number of studies, first on symptomatic carotid stenosis, and then for patients also with asymptomatic carotid stenosis. And this next slide here, this is a recent update of the systematic Cochrane review of all the randomized studies comparing stenting versus endarterectomy for symptomatic stenosis, and looking just at the complication rate, which was defined as death or any stroke within 30 days of treatment. And when you aggregate all the evidence, it was very clear that with these trials done at that time, with the techniques and materials that were available at the time, endarterectomy was clearly better than stenting in terms of treatment safety, with crude risks of perioperative stroke or death of 4.4% in the endarterectomy groups versus 7.3% in the stenting groups. So again, we put together the individual patients' databases of these studies in the carotid stenosis trialist collaboration and looked at the combined outcome from the 4 largest trials comparing stenting versus endarterectomy for symptomatic stenosis, combining procedural harm defined as stroke or death within 30 days of treatment and procedural efficacy defined as the prevention of ipsilateral stroke during follow-up. And when you do that, you can again see very clearly that the difference in favor of endarterectomy occurs early on by about a 3% risk difference in perioperative stroke or death, which favors endarterectomy. But thereafter, the curves run more or less parallel, which means that both treatments are probably about equally effective at preventing stroke. And so that 3% difference is carried forward throughout 10 years follow-up. Now, so when we want to choose between stenting and endarterectomy, it's therefore important that we consider this perioperative risks and try to identify risk factors that might predict perioperative stroke or death. And the strongest such risk factor that we have identified in this collaboration was patient's age. So here on the left-hand side, you can see the risk of periprocedural stroke or death, and the blue line is the risk increase compared with patients younger than 60 years in the stenting group as age increases, and the red dots show the same relative risks in the surgery group of these trials. And you can see that when patients get above the age of 70 years, there's a marked increase in the risk of periprocedural stroke or death with stenting, but not so with endarterectomy. And there's very little impact of patient age on the long-term risk of post-procedural ipsilateral stroke. So age is the only factor that's being taken into account with a good evidence base in the most recent ESO guidelines on choosing between stenting and endarterectomy for symptomatic patients, as you will see at the end of my lecture. So a stenting versus endarterectomy was also compared in patients with asymptomatic stenosis. And until very recently, we only had largely the data from 2 large and some smaller trials. The first large trial was the North American CREST study, a trial of stenting versus endarterectomy that included both symptomatic and asymptomatic patients. And for the primary outcome, which was any stroke, death, or MI occurring periprocedurally, or ipsilateral stroke during follow-up, there was no significant difference between stenting and endarterectomy, either in symptomatic or in asymptomatic patients. And when we just look at the perioperative complications, we can see that again, this extra stroke or death risk in stenting, here it was again about 3%, as in the European trials, compared with endarterectomy, but an increased risk of myocardial infarction in the endarterectomy group, which was about 1% in symptomatic patients. And in asymptomatic patients in the CREST study, this just seemed to balance each other out. So we had about a 1% extra risk of stroke or death in the stenting group, and about 1% extra risk of MI in the endarterectomy group. And these results were largely replicated by another North American study, the ACT-1 trial, which randomized patients in a 3-to-1 ratio between stenting and endarterectomy, again with asymptomatic carotid stenosis. They used the same primary combined outcome measure, and they had to stop the trial after 1,400 patients due to slow enrollment. But the 1-year rate of the primary endpoint didn't differ between the 2 treatments. And also the perioperative risks again showed about a 1% increase in perioperative stroke or death in the stenting group. So last year, when we did the update of the Cochrane review, there was, largely driven by these two studies, but also by some smaller studies, there was just a trend that was almost significant of an increased risk of stroke or death within 30 days of treatment. And just a few days ago, the primary results of the second asymptomatic carotid surgery trials were published, ACST2. This trial compared stenting versus endarterectomy for asymptomatic stenosis in more than 3,600 patients. So it actually doubled the evidence base we had so far with just the CREST and the ACT1 study. And you can see here the risk of the primary outcome in this study was any fatal or disabling stroke or procedural death. And this risk was not significantly different between the two arms. But for better comparability to the other trials I've just shown you, I show you here the risk of any stroke or procedural death, and on the right-hand side, the risk of non-procedural stroke of any severity. And again, we observed this 1% increase in 30-day stroke or death rates in the stenting group. And thereafter, there was maybe a hint of a difference, but of course not a statistically significant difference in the rate of non-procedural stroke. And when we break down the events by severity, as I have mentioned to you, there was no difference between surgery and stenting in disabling or fatal strokes occurring periprocedurally or during long-term follow-up. The extra risk was largely non-disabling strokes, which were more common in the procedural phase, but also in the long-term follow-up phase in the stenting group. This was a pattern, by the way, that was also observed in the symptomatic studies. These extra strokes caused by stenting, usually during the procedure, are largely non-disabling stroke. Now, just a word about the selection of patients for treatment. If we go back to the old endarterectomy studies, the trials I showed you at the beginning that compared endarterectomy with aspirin in patients with symptomatic stenosis, and if we look at all the groups that are considered today for endarterectomy, so patients with 50 to 99% stenosis, even at the time of these trials with very, I would say, non-advanced medical therapy, just aspirin as a comparator, we had to operate 9 men and 36 women to prevent a single stroke after 5 years in each sex. So it's important that we get better at selecting patients for treatment. And as I will show you, risk modeling or plaque imaging might be possibilities to do so. We need to get better in selecting patients for treatment in order not to do unnecessary therapies that are expensive and potentially harmful, especially today, because today I think this number needed to treat is even larger because we have much more advanced medical therapy than at the time of these trials. So the first approach is risk modeling, and if we look at subgroups in these early endarterectomy trials, again, data from Peter Rothwell from his pooled analysis, it's clear that the effect of endarterectomy is larger in patients with severe stenosis than in patients with moderate stenosis. And it was also seen that the effect was larger in men than in women. The effect was larger in older than in younger patients, both for moderate and severe stenosis, and the effect of surgery quickly diminished with the time since the last ischemic event, so that in patients with moderate stenosis, there was only a benefit in the subgroup that was randomized within 2 weeks of the symptom. Then the effects went away, and in patients with severe symptomatic stenosis, the effect of surgery persisted for about 3 months, but also clearly decreased with time. So the benefit of surgery is highest in men, elderly patients with symptomatic carotid stenosis, and if people are treated within 2 weeks of symptoms. And this type of risk modeling approach is something we now evaluate in the second European carotid surgery trial, ECST2. We use a app-based risk model that's being based on these subgroup effects that will tell us if a patient has not very high risk symptomatic stenosis, and the patients who are not so high risk are now randomized again between best medical therapy and surgery. Another way to select patients, which is, I think, very promising as an addition to clinical risk modeling, is plaque imaging. And there are various ways to image the plaque. You can do ultrasound, you can do a CT angio, you can do PET imaging, but I will just show you as an example some of the data from MR, plaque MRI. And on a T1 weighted fat suppressed MR scan, you can identify intraplaque hemorrhage as a bright signal here in the carotid plaque. This means that at some stage there was probably ulceration or plaque rupture, and there was bleeding into the plaque, or the bleeding may have occurred as a consequence of rupture of new vessels that formed within the plaque. In each case, it's a marker, it's a potential marker of plaque instability. And a number of studies have looked at the risk of TIA or stroke in patients with and without intraplaque hemorrhage. And a couple of years ago, we pulled together that evidence and were able to show that intraplaque hemorrhage increases your stroke risk quite independently of the degree of symptomatic carotid stenosis. So, for example, here on the left-hand side, these were patients with just minor degree of stenosis, basically plaques. And if they had intraplaque hemorrhage, though, after initial symptoms, they had quite a substantial risk of stroke after 4 years compared to the patients who didn't have intraplaque hemorrhage. That risk increase was even more pronounced in patients with moderate stenosis and in patients with severe stenosis, and across all the degrees of stenosis. And also, if you adjust for other risk factors that are well established, such as degree of stenosis, sex, age, time since symptoms, etc., you still have an independent risk increase of about 10-fold with having an intraplaque hemorrhage. So again, in the ECST2 study, we're looking additionally whether patients with intraplaque hemorrhage will be the ones who benefit from endarterectomy. Now we're leaving the area of carotid disease and move on to atherosclerosis of the vertebral artery, symptomatic vertebral artery stenosis. And I will just show you a couple of randomized trials and a pooled analysis that were done there, because again, about 2 decades ago, there were observational studies that showed, just as was the case for carotid stenosis, that if you had a vertebrobasilar TIA that was caused by a significant vertebral artery stenosis, your risk of having a vertebrobasilar stroke after 90 days was quite elevated, 20 to 30%, much bigger than the risk without having a vertebral artery stenosis. And this is an example of a vertebral artery origin stenosis on the right side of about 90%. So this is a typical site where atherosclerotic disease of the vertebral artery and stenosis occurs, and this is the same artery after stenting. So the question was, can stenting lower that risk compared with medical therapy alone in patients with a symptomatic vertebral artery stenosis? And there were a couple of trials. The Dutch VAST study that was stopped because of lack of funding after 115 patients with symptomatic at least 50% vertebral artery stenosis were included. And you can see here that numerically there were more events in the stenting arm than in the medical arm, but of course it had very little power. This was no significant result. But if we just look at the 30-day event risk after vertebral artery stenting, there were 2 ischemic strokes, one of which was fatal, and 1 hemorrhagic stroke. So the overall stroke or death rate was 6%, but the 2 of these strokes occurred in patients who had intracranial vertebral artery stenosis, so not origin stenosis. These patients were not excluded from the VAST trial. And 2 years later, Hugh Marcus published the results of the VIST trial, the UK study comparing stenting versus medical therapy in symptomatic vertebral artery stenosis. That trial was also stopped because of slow recruitment and lack of funding, and included 182 patients. And here, the results were the other way around. There were numerically more events in the medical group than in the stenting group, but the complication rates in the stenting group were very much comparable to the Dutch VAST trial. Again, there were 3 stroke or death events, this time 2 ischemic strokes and 1 intracerebral hemorrhage, which was fatal. And again, both ischemic strokes occurred in patients who had stenting for intracranial stenosis. So, of course, the question then was, if we just exclude patients with intracranial vertebral stenosis and just treat the ones with vertebral artery origin stenosis, can we get better results? And the data of the 2 trials were pooled and published in the Lancet Neurology in 2019. And here, this slide just includes patients with symptomatic extracranial vertebral artery stenosis. There is maybe a signal of a benefit from stenting, but the numbers are just too small and the results were not significantly different. But at least I think for extracranial vertebral artery stenosis, they point in the right direction as far as stenting is concerned. Final part of the talk before I move on to the guidelines is symptomatic intracranial stenosis. And here we have some very early data from the warfarin aspirin symptomatic intracranial disease trial that compared 2 medical regimes. One was warfarin, one was aspirin, in patients with at least 50% symptomatic intracranial artery stenosis. The trial had to be stopped because there were more bleeding events in the warfarin arm, but after about 2 years follow-up, you could see a couple of things. A, there was no difference between warfarin and aspirin in the recurrent rate of stroke or the risk of vascular death combined. It was about 20% 2-year cumulative risk. And B, you can see that this risk is quite high. I mean, this is a big risk of for someone surviving a stroke or TIA to have another stroke of 20% after 2 years. So the idea was, again, maybe stenting of intracranial arteries might lower that risk. And the first large trial that tried to answer this question was the SAMPRIS study that used a self-expanding wingspan stent compared with medical therapy in patients with severe symptomatic intracranial artery stenosis. But that trial had to be stopped after 415 patients because the risk of stroke was higher. The risk of perioperative stroke was too high in the stent group. You can see that risk here, events within 30 days after randomization in the stent group. Now just put this away for a minute. In the stent group, there was a 10% ischemic stroke risk and a 5% hemorrhage risk. And B, in the medical arm, the risks were quite much lower than was observed in the earlier WASIT study. So the trial was stopped because there was obviously no way that the initial harm of stenting would ever be counteracted by a later benefit of stenting, because you can see here, these are the data from the longer term follow-up after a median of 32 months. This initial harm of intracranial stenting is carried forward, is not being outweighed by some later benefit during long-term follow-up. I think what we can learn from this study is also that medical therapy as administered in the comparator arm was quite effective, and that included double antiplatelet therapy again in the first 90 days. And a second trial used a slightly different stent device, a balloon expandable stent, the Vitesse stent, and had a similar design, also evaluated this against medical therapy alone, including 3 months dual antiplatelet therapy in patients with severe symptomatic intracranial stenosis. The trial was also stopped after 112 patients because the data of SAMPRIS were released. They did an interim analysis and noticed, okay, it's futile to continue and probably also not safe to continue with the trial. Here, the primary outcome was stroke or hard TIA, being defined either with a high clinical probability of TIA or imaging confirmation of ischemia in the dependent territory within 1 year. And very similar to the SAMPRE study, also in the VITESS, in the VISIT trial, there was a substantial risk of ischemic stroke occurring periprocedurally, 17% in the stent arm, and also a substantial risk of intracranial hemorrhage. So now the final chapter will be dedicated to the management recommendations. And again, I will start with the recommendations on medical therapy for large artery atherosclerosis and carotid stenosis in particular. These are taken from general atherosclerotic event or atherosclerotic disease prevention guidelines, and sometimes referring to data that were derived from carotid subgroup analyses from trials. But in recently symptomatic carotid stenosis, we recommend early limited duration dual antiplatelet therapy, 30 days up to 3 months, with aspirin plus clopidogrel or aspirin plus ticagrelor in patients who had a recent minor stroke or TIA and are not considered to be at increased risk of intracerebral hemorrhage. And I would administer this even to patients who are referred rapidly for carotid endarterectomy or stenting, because, as you have seen, the effect takes place in the first few days after the event. And if we start early, we can also prevent recurrent strokes occurring in patients waiting for endarterectomy or stenting. In stable carotid disease, so say asymptomatic or more than 1 month after symptoms, you can consider either antiplatelet monotherapy or this new combination of low-dose rivaroxaban, twice 2.5 milligrams, plus aspirin 100 milligrams daily. All patients should receive a probably ideally high-intensity statin therapy with a goal of lowering LDL cholesterol below 1.8, ideally now below 1.4 millimoles per liter. And we should consider adding ezetimibe or even switching to PCSK9 inhibitors to reach that target. And there are the regular targets for blood pressure lowering and glycemic control in patients that apply to patients with carotid disease as well, in addition to counseling on risk factors such as smoking and lifestyle modification, of course. Now, if we go on to the recommendations on endarterectomy or stenting for carotid stenosis, I'd like to present here the guidelines, or a summary of the guidelines that we developed on behalf of the European Stroke Organization. In patients with asymptomatic carotid stenosis, for the question of endarterectomy versus medical therapy, we recommend in patients with at least 60% asymptomatic carotid stenosis who are considered to be at increased risk of stroke, we recommended carotid endarterectomy based on a moderate quality of evidence, but it was a strong recommendation by the group. That markers that might confer or might identify patients to be at increased risk of stroke are provided here in the supporting information section. They include silent infarction in neuroimaging, high degree or progression of asymptomatic stenosis, echolucent plaque on ultrasound, intraplaque hemorrhage on MRI, and microemboli or reduced cerebrovascular reserve on transcranial Doppler. Now, in one of the trials, I didn't show you that subgroup analysis, in one of the trials in the first ACST study, there was apparently no benefit of endarterectomy versus medical therapy in patients with asymptomatic stenosis who were 75 years or older. But because this was done a long time ago, because it was a subgroup analysis, and because we think that since that time, the life expectancy of patients with vascular disease has increased owing to advances in medical therapy, we still suggested a carotid endarterectomy in selected patients with asymptomatic stenosis who are older than 75 years, if they have an expected survival of at least 5 years. And of course, this should be done after careful considerations of risks and benefits in multidisciplinary team meetings, but this is the case for any carotid intervention. Going on to stenting versus medical therapy. Sorry. This I don't need to show. I want to go straight on to stenting versus endarterectomy for asymptomatic stenosis. And these were recommendations, as you are aware, given before the publication of ACST2. We made a suggestion for endarterectomy as the current treatment of choice in patients with asymptomatic carotid stenosis who are considered to require revascularization. It was a weak recommendation. Of course, that might now change to a more strong recommendation with the data of ACST2, which again showed a slight benefit of endarterectomy compared with stenting. We also issued an expert consensus statement saying that in selected patients who are less suitable for surgery, stenting may be suggested. We also recommend to monitor in-hospital stroke or death rates and said that in order for stenting or endarterectomy to have a beneficial effect in patients with asymptomatic stenosis, these in-hospital complications rates should be as low as possible, ideally below 2%. Moving on to symptomatic stenosis, again, first for the question endarterectomy versus medical therapy alone, we made a strong recommendation for endarterectomy in patients with severe symptomatic carotid stenosis. And a weak recommendation, this was the terminology, we suggest carotid endarterectomy in patients with only moderate symptomatic carotid stenosis. And and a strong recommendation against carotid endarterectomy in patients with only mild stenosis for the time being. Again, you have to bear in mind that these guidelines do not yet take into account potential selection benefits as far as plaque imaging and risk factor modeling is concerned, because these tools have not yet been shown in randomized trials that they actually identify patients with minor degree of stenosis that might benefit from endarterectomy. It's possible that this might change in the future. Now, in patients who are considered candidates for surgery, we recommend early treatment, ideally within the first 2 weeks of the initial neurological event. Now, for the choice between stenting and endarterectomy in patients who require revascularization for symptomatic stenosis, we strongly recommend endarterectomy as the treatment of choice, but in the subgroup of patients with symptomatic stenosis below the age of 70 years, we suggest that stenting may be considered as an alternative to endarterectomy. The data so far show no difference in preoperative rates of stroke or death and equal prevention of stroke and avoidance of restenosis between these two treatments. So it is an option in younger patients with symptomatic stenosis. But the choice between the two treatments should also take into account anatomical and morphological features. And again, we said for any procedure done in symptomatic patients, the risk of in-hospital stroke or death should be as low as possible and not exceed 4%. Now, some personal recommendations for symptomatic vertebral artery stenosis. I think the treatment of first choice is still modern medical therapy, including aggressive cholesterol-lowering antihypertensive therapy and antiplatelet therapy, ideally dual antiplatelet therapy in patients with minor stroke or TIA. And we should consider stenting or transposition surgery only if recurrent symptoms occur despite best medical therapy. And a very similar recommendation can be made for first ever symptomatic intracranial stenosis. The treatment of first choice, again, is for the time being medical therapy. And here we have pretty good evidence from the medical comparators of the stenting trials that we should give dual antiplatelet therapy for 3 months with aspirin and clopidogrel in patients who have symptomatic intracranial stenosis. And again, we should consider angioplasty or stenting only if recurrent symptoms occur. The future might be not in actual mechanical stenting of intracranial disease, but in drug-coated balloons that are probably associated with a low risk of perioperative stroke. And this is my last slide. I thank you very much for your attention. And again to you, David, for the kind invitation to speak to you today. And now I'm going to stop sharing my screen, and I think we have plenty of time for discussion. Thank you.
Thanks very much indeed, Leo. That was superb. Really detailed, really up to date, and with some excellent practical recommendations for us at the end. So really excellent overview of that topic and bang up to date. So thank you so much for that. So I'm sure there must be some questions while people are maybe having a think about their questions. If I could ask you one, Leo. One of the things we talk about quite a lot is when to check for platelet, the effect of drugs on platelet function and whether there might be resistance to the effect of antiplatelet therapies. And I must admit, personally, I find it difficult to know how robust the evidence is for us to be using this sort of approach. But nonetheless, some of our interventionists do use this to look at the response to antiplatelet agents in people in whom they've put stents in, for example. And there's a wide variety of practice, I think, around the UK and elsewhere. And I just wondered what's your current approach to platelet testing response to drugs?
Yeah, that's an excellent question. Thank you, David. It's also a difficult one because from a mechanistic point of view, yes, you want to see in vitro that your drug works, you're sure the patient is protected. But actually, as you mentioned, there's very little evidence that the platelet reactivity we measure in vitro has anything to do with the clinical effect. We don't measure platelet reactivity routinely, even before carotid artery stenting, for example. And I know of a few sites who do that, especially in Germany, and who then even recommend switching to ticagrelor when there's no effect of clopidogrel. And you may be aware we're currently running this trial, this small MRI-based trial, where we compare these two regimes, clopidogrel plus aspirin versus ticagrelor plus aspirin, in patients who are undergoing carotid artery stenting, looking at the embolism rate on DWI. And hopefully in the next year, we will see whether ticagrelor might have an effect. And if this is the case, then the same thing will happen as at least in Europe and in Switzerland. What happened in cardiologists is that cardiologists just switch to these more potent, more modern P2Y12 inhibitors, such as prasugrel or ticagrelor, that no longer require antiplatelet testing because they're direct drugs. And they abandoned testing, they abandoned clopidogrel in their procedures. So we will see. But I think if there was really a relevant clinical meaning of these tests, I think we would all be doing them much more often today. And it's still, as you said, it's still disputed whether they have any clinical meaning.
Thanks, Leo. I mean, even with that, within our service, there's a huge range of enthusiasm for these tests. So I guess we will have more data soon. Dr. Luder is one of our consultants from the North Middlesex. He's got his hand up, I think.
Hi, thanks. That was a brilliant talk. Can I just check whether you think there is an argument to repeat any of the carotid trials, given that they are fairly old and not against best medical therapy as we have it today?
Yeah, I strongly think this is the case. It's one of the reasons we started ECST2, which basically compares endarterectomy versus medical therapy in symptomatic or asymptomatic patients that are pre-selected with clinical risk modeling. We want to be sure not to include the so-called high-risk patients. Unfortunately, we never get past the pilot phase, which it will run out now at the end of the year. We will have some data also with follow-up imaging next year, I'm hoping. But it was difficult to get funding for a large trial. But I think you're right. I think even in symptomatic disease, the trials should be repeated. As far as asymptomatic stenosis is concerned, there is a large study, the CREST-2 study now, looking at endarterectomy versus stenting and endarterectomy versus medical therapy and at stenting versus medical therapy in 2 parallel studies in patients with asymptomatic disease on the background of aggressive modern medical therapy. And we will see if there is still an effect. We also have to bear in mind that the interventional risks and the perioperative risks of carotid procedures also came down over time. So there might still be a residual benefit, but I agree with you, it is likely to be smaller than what was observed in these early studies.
Thank you very much.
Thanks, Leo. Any other questions coming from the group? Jonathan Best, who's a PhD student.
Thank you. I wondered if you had any comments on how we should modify our antithrombotic strategies in patients who also have atrial fibrillation, as well as significant carotid artery disease.
Yeah, that's a good question. Now, we looked at this in a large in a large international consortium of patients who have atrial fibrillation, and in some and especially in patients who had atrial fibrillation and then had a stroke despite atrial fibrillation, and of course, in some of these cases, additional competing etiologies were found. But overall, in those patients where aspirin, for example, was added to a NOAC, we observed the highest complication rates and also recurrent risk rates, which is probably a selection bias. These are probably also the patients at highest risk for having an event because they have some atherosclerosis, and we're looking at this at the moment. Individually, I think there's if it is a minor stroke or TIA, if the pattern of and this is where MR will help you. For example, the pattern is consistent with also a potential atherosclerotic cause of embolism. So you have all the emboli lined up in the internal border zone or on one side of the brain. You have no big risk of bleeding. Then I don't think you risk a lot by just adding as long as you're not considering endarterectomy, you can just add aspirin maybe for a month, because we know that platelet stabilizing effect of antithrombotics, of antiplatelets, as I've shown you on these curves, it takes place early on. So maybe an early limited duration of add-on therapy might be beneficial in some patients who you continue treating conservatively, or even to bridge the time until endarterectomy. But this has not been shown in randomized studies. There are some contrary signals from large registries, but I think they're biased by selection. And so it's a personal choice. I don't think you're risking a lot if it's a patient with a minor stroke or TIA, and if you limit the duration of aspirin add-on.
Great, thank you very much.
Thanks, Leo. That's encouraging. That's sort of in line with some of the decisions we make in our MDTs as well. So I got a question. I don't know how much you touched on this regarding the role of brain imaging in patient selection, and I know you've published on certain biomarkers that might affect the differential response to either stenting or surgery for carotid disease. So things like leukoariosis, cerebral microbleeds. I just wondered if you'd like to comment on whether that has a role.
Yes, we made this observation in ICSS that patients who had moderate to severe white matter disease had an even higher extra risk of stroke occurring with stenting. Some of the hypothesis was that we observed these largely asymptomatic emboli quite a lot, of course, after stenting, as we've also shown in the ICSS trial. And one hypothesis is that maybe patients with additional severe white matter disease have less to compensate, so they might, they might react symptomatically to these otherwise asymptomatic lesions, and then this might then cause a stroke. We haven't been able to separate this in the ICSS MRI sub-study because the numbers were too low. Personally, I feel strongly about the age argument, and if you look at the younger population below the age of 70, There might be some extra risk by white matter disease, but it's probably not as relevant as for the older patients, which we shouldn't stent anyway, I think, for the time being. The other marker we're often confronted with is of course, your specialty is cerebral microbleeds, but we know from your research and also of course from the fact that we only provide limited duration antiplatelet therapy, even in patients who undergo stenting. I don't think it's as much as a concern as we initially thought.
Okay, wonderful, thank you. Who else has got a question? I don't want to be hogging the questions, but I don't know if I can go slightly off topic. It's still to do with the carotid though. You will have seen the results of the TREAT-CAD study for dissection.
Yes.
And,
yes.
aspirin didn't seem to be non-inferior to warfarin, and we've been sort of struggling to make sense of these results and whether it should really influence our treatment of dissection in any way. And it's another thing that there's a huge variety of clinical practice. We often use dual antiplatelets, for which there is probably even more limited evidence for symptomatic dissection. So I just wondered, what's your pathway for the management of dissection in Basel? You must be the most informed centre in the world.
Yeah, because I'm sharing an office with Stefan, who was the chief investigator of the study. So yeah, it kind of, you know, when Stefan started the study, he was intrigued by the fact that everyone, especially people in Germany and France, gave heparin, full dose anticoagulation in patients with dissection, and there was actually no evidence to do that. So he actually went back and said, wait a moment, let's try aspirin. And if aspirin is not inferior to heparin and subsequent warfarin, it's a much easier therapy. We should all switch to aspirin. And unfortunately, he wasn't able to show that, as you're aware. And in fact, there were numerically a few more events in the aspirin arm. So we, in addition to not being able to show it's non-inferior, we might actually harm some people. So we went back to what we did before the trial, which was we gave heparin to patients who had a dissection and a cerebral ischemia that was not at high risk for bleeding, so no major stroke. So a dissection plus minor stroke, or TIA. We again start with heparin and switch over to warfarin for, usually about 3 to 6 months, and then de-escalate to aspirin. In patients who only have local symptoms, so let's say only Horner syndrome or pain or a cranial nerve palsy, and MR scan rules out even asymptomatic embolism to the brain, we still feel safe with aspirin, because Stefan observed that in this subgroup of patients with just local symptoms, there were actually none or hardly any outcome events in either arm. So we went back to that strategy. And of course, a future question that Stefan might look at is whether instead of heparin plus warfarin, we might also give NOACs to these patients for a limited time.
So that's interesting. So heparin and warfarin still?
Yeah, for the time being. Yeah.
That's interesting. And I guess there's lots more trials to be done with DOACs.
Exactly, yeah, exactly. People start using them. I wouldn't be, we've seen that they don't always work. For example, the patients, the trials with mechanical heart valves, where they were inferior to warfarin. I think, again, this is something that should be tried in a study, but it is of potential attraction, of course, if we can just give limited duration DOAC to patients and then de-escalate to aspirin.
Okay, great, thank you. I mean, this is so useful. It'd be great to have you in our MDTs, actually.
It's great to be there, even if I'm not there, and to join and participate in the discussion.
You could join now that they're on Teams, actually. But okay, any other questions, anyone? We've worked Leo quite hard here. I mean, if I can ask just one last one, is
yeah.
You've showed us the evidence on ticagrelor which is emerging. Again, it's about your practical approach to that. When would you use clopidogrel? When would you use ticagrelor in somebody with symptomatic large artery disease in practice?
Yeah. I find there are some niche indications for ticagrelor and aspirin. I think if you look at the definition of minor stroke, that went up to I think NIH of 3 in the CHANCE study and in the POINT trial, and in the THALES study with ticagrelor, this also included patients with 4 to 5. So it was tested in a range that was somewhat more severe, but it's still minor stroke. And the other thing which I find more convincing in THALES is what you mentioned, is the atherosclerosis sub-study, because in THALES we know that the patients with ipsilateral at least 30% narrowing of an artery have quite a substantial benefit of, 3% after 30 days is pretty good on the background of a well-controlled population. And I didn't show you that, but the POINT study with clopidogrel and aspirin was not able to show that. And the Chinese CHANCE study only showed it for intracranial stenosis. So I still think there's a role here for ticagrelor aspirin combination in patients with atherosclerotic stroke or TIA. I think in these patients it might actually be better than clopidogrel plus aspirin. We'll never have a trial because I don't think AstraZeneca will extend the research program. And also it was unfortunate, but just a few weeks ago we heard that they didn't get the label change in Switzerland for it to be used in patients with minor stroke or TIA. They have the permission in the United States for the FDA, and they're now applying to the EMA as well. But at the moment, we cannot use it routinely. We can only use it in selected patients. I think there is a role in those with atherosclerotic stroke or TIA.
Okay. And I guess the guidelines are not really helping us quite yet, have they? Because it's not filtered into the guidelines yet.
I don't think it's filtered in yet to a relevant degree now.
Yeah. Well, I don't have much experience of using it, and I'm not sure if our colleagues on the line have yet either. But that's a useful steer in the groups in which we might consider it. Okay. So who's chairing the meeting? Is it? Oh, well, I've sort of tried to chair it, but. Fiona, can you remind me what's on the agenda, and do we let Leo go, or do we ask more questions?
I think if there are any more questions, that's great, but otherwise I think we can let Leo go.
Well, thank you very much again.
Thank you so much.
And have a successful meeting.
Yes.
Yeah, we've really enjoyed it, Leo. Excellent. There would be a very loud round of applause if we were in a room.
Thank you
so much. Really
great to have me. Thanks for the invitation again and for joining in quite large numbers. Thank you.
Great.
Pleasure. Thanks a lot.
Bye.
Leo. Take care. Bye-bye.
And thanks again to Suman for putting us in touch. That's wonderful. Thank you.
Oh, yeah. Thanks, Suman.
Yes, thanks, Jonathan.
Cheerio. Thanks very much. So, Fiona, is that the end of the meeting, or do we...
I think so. I don't think, unless we have any of the research team, I haven't heard that, but they might want to jump in.
Can I just mention one thing, Fiona? Very, very briefly. You probably saw the timing trial was at ESOC, which was a bit like Optimas, and it didn't really give a clear evidence that early anticoagulation was well, it showed basically early anticoagulation seemed to be non-inferior to standard anticoagulation after AF cardioembolic stroke with a DOAC treatment with a DOAC. But we just wanted to emphasize that despite that evidence coming through, firstly, it under-recruited. Secondly, it seemed to be quite a minor stroke population in terms of the NIHSS. And we don't have evidence on the relationship of the infarct size to the response to treatment. So what I'm saying is we still should have equipoise. And it still strongly supports randomization into Optimas and in other countries into ELAN. So I just wanted to plug Optimas again, really. So anyone who thinks they don't have equipoise, you should have.
Yeah, And any juniors, if you clerk anyone who has AF and a stroke, or anyone who is found to have AF in the first few days on HASU, think about Optimat and speak to the research team.
Can I just check with David? That includes restarting anticoagulation, doesn't it? It's not just fresh new AF.
Absolutely, Bob. And yeah, just to say, the vast amount of evidence, really observational evidence, is on very minor stroke. So really what we need is people with moderately severe strokes in whom there's still great uncertainty about the timing of DOACs. Okay, there are more than 9 people, Fiona, are there? There are other people in the gym or somewhere, are there? All?
I think some of the people might be sharing a computer, sharing a login, possibly.
Okie doke. Anyways, terrific talk by Leo, wasn't it? Absolutely.
Yeah, about 18, I think, at the max.
Definitive talk, I'd say.
Yes, yes.
Really good. So we make sure all our local guidelines incorporate all that evidence. So Arvind isn't here, actually.
He was here for the first 45 minutes, I think.
Oh, was he? Brilliant.
It's a shame he wasn't here for the discussion, I agree. Great, so thank you, everyone. Just to let you know, there will be some slight date changes for the next 2 stroke education meetings, and that is to accommodate our neurosurgical colleagues who Ahmed Toma is going to talk to us about surgery in stroke, in acute stroke, and Pedro Castaño the next month is going to talk to us about incidental aneurysms, AVMs, how to manage them. But unfortunately, both of them have lists on Wednesday afternoon, so we've had to do a little bit of shuffling, but I'll send an email around about that.
Wow, those would be great talks, Fiona.
Yeah. Great. Thanks, Paul.
We could invite the neurosurgery trainees, could we, as well?
Yeah, why not?